Welcome to the Long-Term Care Chronicles podcast. In this episode, we're going to be speaking with Dr. Sharon Straus from the University of Toronto, who was a member of the working group with the Royal Society of Canada on the report for Restoring Trust, COVID-19 and the Future of Long-Term Care, and this will be a two-part series. Let's have a listen. So thank you so much, Sharon, for coming on to the Long-Term Care Chronicles. I really appreciate your time to talk about the report that the Canadian Royal Society has done. So first of all, I just wanted to go to in terms of the origins of long-term care that was mentioned in the report and how that has impacted us, the way that we govern and the way that we look at long-term care in Canada and why this needs to be under the Health Canada Act.
So thanks very much, Wendy, for the chance to chat with you today and to speak to the report. Before I start, I do want to acknowledge the land on which I work and on which I feel very fortunate to work, and recognizing the territory's long history predates the European colonies, and also acknowledge the significance of the territory for the Indigenous people who lived on this land and continue to live on it. And in particular, I'm based at St. Mike's in Toronto, and it has been the traditional land of many diverse First Nations, Inuit and Métis people, including the Mississaugas, the Wendat, the Anishinaabe, and the Haudenosaunee. And I'm really, really grateful to be able to work on this land and also to learn from the knowledge keepers, many of whom are the elders in the community. So I appreciate the ability to learn from them. And also wanted to acknowledge that in particular committed to recognize, honor, and take action on the Truth and Reconciliation Commission and the Missing and Murdered Indigenous Women and Girls Inquiry Calls to Action. So you asked about kind of the how it's governed and the history of how long-term care got set up in Canada. I think that's a really important question because, as you know, long-term care sits outside of the Canada Health Act, and really the way it works is that, federally the funding, as you know, comes from the federal government, but then it goes to the provinces and territories who then are responsible for what happens on the long-term care front. And so this has led to some particular challenges because everything then, happens very differently in each province and territory. And one of the big challenges, for example, is that, we don't have great data from province to province and on kind of, how many staff we have in long-term care, for example. There aren't any good repositories of any of that information. And so the fact that there's been this bit of a disjointed approach then means that we don't have the absolute best tools at our disposal to make sure that long-term care is getting the support that it needs across Canada.
Yeah, thank you so much. But for where long-term care originally started, I mean, it probably wasn't used the same long-term care, probably the poorhouse type of, just to provide that a little bit more of that type of background. So
exactly. So it does come from, in the 1600s that, the traditions of the poorhouse and then it's really only been more recently that people have, even the terms that we use, it used to be long-term care hospital. And then, the term has gradually moved into that and recognizing the importance of that this is a home for people. And incorporating that as part of the name, but and so I think it's really been interesting if you look back at the history of how long-term care started and the origins of it and how we've ended up to where we are today. It really does take root back in how it was started. And so if you think about it as kind of being initially in the almshouses and the poorhouses that it was set up, and then now this has kind of evolved into long-term care. I think that says it all.
Yeah. Definitely. And then the fact that we've had 50 years of commissions, reports on how to improve long-term care. Mm-hmm. I know the report, talked to at least 4 points to this. What can you be able to indicate to these 4 points of how that should be improved moving forward?
Yeah. So, and it's a great point that you raised around how many reports, because we don't need another report. We don't need another commission. We don't need another inquiry. Yeah. All of these fantastic reports that have been produced in the last few years. And, two of our graduate students, Eric Wong and his colleague, looked at how many reports have been done in Canada and how much money it costs to produce those reports, and how much, that could have been spent on actually implementing the recommendations in the reports. And, so it's really about looking at the recommendations that those reports have highlighted. And so one of the things that we really wanted to focus on in the Restoring Trust document was summarizing all of that fantastic work that's been done and saying, it's been done. We know what needs to happen. Now we need to focus on doing it. And in particular, we wanted to focus on things related to the long-term care staff. This is a group of people that are undervalued, underpaid, and they are at the front line. And so that was one of the key things that we really wanted to focus on. And in particular, highlighting that if you look at this population, as you know, more than 90% of them are women. A majority of them were born outside of Canada, first language not English. These are racialized women. The average age, or the median age, is older than the median age of the rest of the Canadian workforce. So I also think that's a big factor into why this workforce doesn't get the value that it should. It's very much it's a gender issue, and it also reflects that we need to take what we often call as an intersectionality lens, where we look at the intersection of gender and age and race and language and socioeconomic status, and how important those factors are, and in particular with this workforce. And I think that to me has been one of the key challenges, and not having the data on how many staff we have, not having the data on the appropriate staffing mix, the fact that they get paid less than half of their acute care counterparts, that many of them are working part-time at multiple sites prior to COVID outbreak because they couldn't get full-time work. And so the challenges attached to that. So those are all, I think, critically important factors related to the staffing level of the staff. The second thing is we also talked about kind of the staffing mix and model, and it's interesting that as I mentioned, we don't have great Canadian data on first of all, how many workers do we have in long-term care? We don't have any data on how many personal support workers there are. We don't have any data on how many hours of direct care are provided by all of these different individuals across the country. BC has done some great work a couple of years ago where they looked within their long-term care sector and identified kind of how many hours of direct care, and indirect care, and who was providing the direct care. And they actually set a target that they wanted to reach, like a much higher target. And they used data from that was largely from the U.S., a study that was done about 15 years ago.
Okay.
And then more recently, there was a study from Australia. But if you look at that, that's in BC, but it's not similarly been done in the other provinces, and we still don't know kind of where we are at this particular point in time. The other piece that we spoke about was the need for access to the approach to the multidisciplinary team. So thinking about access to physiotherapists, occupational therapists, speech therapists, spiritual care, dentists. There's so many of these other disciplines that need to be considered, and again, we don't have good data on that, and similarly, what is the optimal mix? So what should be available? Then also thinking about from the primary care perspective, some of the models are having the when the person moves into the long-term care home, that their primary care physician is the same primary care physician that they had in the community, and they follow them in, versus having a primary care clinician attached to that long-term care home, which is the best model. And so, part of it is understanding that and the role of others in providing primary care as well. So the role of nurse practitioners, for example, So those are some of the issues that we identified. The need to ensure that families are incorporated in this and that their family voice is heard and that they're engaged in all of these discussions around how do we optimize the quality of care and long-term care. Certainly, as you know, during COVID, that was one of the most heartbreaking things, I think, for everybody was, to see the families and other caregivers not being able to visit their family members in the homes, and distressing for the residents, distressing for the families, and distressing for the frontline workers to see that and have to experience that too. And so thinking about how do we ensure that the families and other caregivers are supported in future outbreaks, but also what are the optimal ways to ensure that that their voice is really heard as we discuss these things, and that they're at the table. And then the other things that we talked about were ensuring that that we have funding from the federal government to the provinces and territories, but that provinces and territories are held accountable for what that funding is used for, and that it's tied to quality indicators. And that we should all be coming together to saying, okay, based on these reports, we have great things around thinking about what the quality indicators should be, from the resident perspective, from the family perspective, from the workforce perspective. There's a lot of quality indicators relevant to all those different participants. And so it's thinking about, making sure that we have an accountability built in around those quality indicators, and then have the data to be able to measure that. Because saying, we're going to look at, access to palliative care, quality of, comfort measures at the end of life, nutrition, whatever we want to think about from a quality indicator perspective, but then not being able to have the data to measure that, to see, are we actually doing what we want to be doing? And as you know, we can't manage without being able to measure.
Exactly.
And so it's really critically important that we have that data to be able to support that. So I really, one of the things that we talked about in the report was really seeing a national agreement on the quality indicators, and that the federal government then would align the funding with those quality indicators.
Yeah, absolutely, that is definitely needed in order for it to be the same across the province, across the country. So in regards to, I guess, with the pandemic, it revealed that there are some major challenges. There definitely is some long-rooted issues that are happening in long-term care, and the report did talk to that. Can you just highlight some of those specific challenges?
And it's interesting because one of the things that we said is that the pandemic didn't highlight any new information about long-term care. So, and it was interesting because I think a lot of times in the media, as you know, that's kind of what got portrayed, that, oh, this is like new, we didn't know this before. And like none of it was new. The only thing that was new was the infection itself, and the fact that, the long incubation period, it was actually the features of COVID itself that kind of triggered what ended up happening. And in particular, I think it highlighted that, we'd had all these reports, we'd had all these recommendations on what to do, and that COVID, just because of its long incubation, asymptomatic transmission, really highlighted this. And I think the other things that it really highlighted as well is that the residents within long-term care, I think people maybe haven't been as attentive to seeing what's happened with the residents in long-term care, and in particular, how complex they are. If you look at kind of the age and the comorbidities, the number of medications that people are on, 2/3 of them have, they're living with dementia. this is a very, very complex population, and medically complex, socially complex, functionally complex. And I don't think that that our population as a whole has had a really good understanding of the complexity of the residents in long-term care, and the care needs, and how the care needs have really gone up. And so I think that certainly COVID has highlighted those issues for people and made people aware of those things that they probably weren't aware of. And then similarly, I think that we talked about it really being a perfect storm. That the fact that this infection and the characteristics of the infection, and how quickly everything happened, and then the lack of access to PPE, personal protective equipment, the lack of access to infection prevention and control, the fact that there was a lot of preparation happening in the acute care side of things, but it was happening in silo from what was going on in the long-term care side of things. And again, I think it reflects the lack of integration within our health and public health system. That, and I think overall, what's happened with COVID has really highlighted those silos, and that what happens in acute care, what happens in the community, what happens in long-term care, what happens in rehab. There's not necessarily a lot of integration across, and yet what happens in one sector is going to impact what happens in the other sectors. Yeah. And so, as whatever happens in the community, there's going to be a ripple effect elsewhere. Whatever happens in long-term care, there's going to be a ripple effect. Yeah. And so I think that that's one of the things that was really highlighted about, I think everybody likes to think that we're kind of in these different sectors, yeah, but we are interconnected. But unfortunately, we're not organized in that way. And so, I think it's highlighted that fragmentation in the system. And also within the, we're talking about long-term care, but you saw the same thing with other congregate settings, yes, as well. Like in, people who were using the shelter system. It was the same kind of thing, and it really highlighted kind of the gaps in our system, which I think for many of us were very, very distressing to see.
Thank you for listening to today's show, and if you have any feedback or suggestions for this or any other episode, please contact us on our social media at Twitter at Family Councils and at Facebook, Family Councils Collaborative Alliance. Thank you so much, and hope you enjoyed this episode.